My name is Dr. Sabrina Islam. I'm an assistant professor of medicine at the Lewis Katz School of Medicine at Temple University. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on echocardiography laboratory practices in the era of COVID-19. Please note this presentation was recorded on May 14th, 2020, and the information was up to date as of that time. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions you may have. I have no disclosures to report. During this presentation, we'll identify risk stratification methods for the echocardiography lab. Additionally, we'll discuss best practices for personal protective equipment or PPE use when performing routine transthoracic echocardiography. We'll also review current recommendations for PPE usage during transesophageal echocardiography. To get started, it's important that we understand the modes of transmission of the SARS-CoV-2 infections. And so there are several modes of transmission that we should be cognizant of during our transthoracic as well as our transesophageal echo studies. One mode of transmission is direct transmission through contact. And this can be through direct transmission from provider to patient, as well as through surfaces that we encounter during our studies in our clinical spaces. Additionally, the virus can be transmitted through droplets which are greater than 5 micrometers in diameter and can traverse areas that are less than 6 feet in distance typically. Finally, for procedures which may generate aerosolization, we may see that these droplets are less than 5 micrometers in diameter and can travel greater than 6 feet in distance. So best practice in our echocardiography lab for many procedures, if possible, would be to maintain greater than 6 feet of distance to minimize spread of infection. However, this is often not feasible during our routine studies, as many procedures that we encounter in our echocardiography lab require closer contact with our patients. And so the American Society of Echocardiography, as well as a number of other governing bodies, issued a statement on protection of patients and echocardiography service providers during the 2019 novel coronavirus outbreak. In understanding that transthoracic echoes are typically prolonged procedures which require this direct patient contact when appropriate precautions should be taken. TEs are more substantially invasive and can potentially generate aerosolization, and so further precautions may be indicated. Finally, in our echocardiography lab, exercise stress testing can promote the spread of respiratory droplets in greater quantities and further distances. Thus, these studies should be limited if performed at all during this time period. Determining how we should decide whether or not to perform an echo, we should ask ourselves, is an echo indicated at this time? And if we determine that an echocardiography study is non-urgent and can be deferred or rescheduled for a later date, then that option should be considered strongly. However, if there is a strong indication for an echocardiography study to be performed, we should then try to identify whether or not we have confirmed or suspected COVID-19 infection in our patients. If there's low suspicion for infection, or we've verified that our patients indeed do not have a COVID-19 infection, then we can opt potentially for standard precautions when performing a routine transthoracic echo. Keep in mind, however, due to the invasive nature of transesophageal echocardiography, we may still consider pursuing either droplet precautions, or for higher risk individuals, we may even consider opting for complete PPE usage in an aerosolization procedure. So once we've determined that our patients have indeed confirmed infection, however, Then we should follow our second algorithm here that you can see, where we determine the nature of study that's indicated, trying to opt for the least invasive study and considering more invasive studies only if absolutely necessary. So if a transthoracic echo study is sufficient, then we should opt for that over transesophageal echo and try to assess as much information as possible for our patients. And we should also determine the location of our patients to decide whether or not certain types of precautions should be taken. And so when we're pursuing studies within the ICU setting or in the operating room setting, or if we have individuals that are either on invasive or non-invasive ventilation, where there's a higher risk of aerosolization generation, we may still opt for airborne precautions at that time. If you look down here on the bottom right-hand side of our flow sheet, just keep in mind that there are special considerations that we're implementing at this time, and certain protocols can be utilized, such as a focused, limited study for certain clinical indications, or a point-of-care ultrasound can be opted for as well. We should also keep in mind the special precautions we should take within our lab, keeping in mind the health and safety of our staff and trainees. And so we should limit staff participation to essential personnel only, and we should also limit exposure to individuals that may be greater than 60 years of age, have chronic medical illnesses, be immunocompromised, or may be pregnant. And this is a summary of recommendations for policies and procedures that may be implemented in the echocardiography lab. And we should, like we mentioned earlier, try to defer and reschedule studies that are non-urgent at this time. And we should always assess the status of each of our patients that we do opt to perform a study and stratify them into low risk or confirmed as not having COVID-19 infection, those that are highly suspicious or suspected, and those that are confirmed as having infection. And we should also provide an appropriate level of self-protection depending on the nature of the study that we're performing and the clinical status of the patients. So what we should keep in mind is that TEs are higher risk procedures, and that individuals that are in more critical states and maybe in certain levels of ventilation may also have higher risks of transmission of disease. Certain institutions may have institutional PPE conservation protocols, and we should also be cognizant of that as well. And this leads to why we should try to defer any non-urgent studies to conserve PPE for those studies which are absolutely indicated and appropriate. Point-of-care ultrasound, additionally, provides a great modality that can supplement our traditional echo studies, as it can be performed by individuals that are trained in already caring for a patient and are already donning appropriate PPE when interacting with the patient. We should also try to limit our exposure during these exams with our modified protocols, but also try to modify how we perform each of our study to minimize our time spent during direct contact, as well as try to minimize the amount of time patients spend in different clinical spaces. And those patients that are deemed to be high-risk individuals should perhaps have bedside studies performed to minimize how much time and space they spend traversing other clinical areas and how many other individuals they come in direct contact with. So once we've decided that a certain study is appropriate and absolutely indicated, certain strategies can be implemented in the echocardiography lab to try to minimize risk of transmission. And so here what we see is in a cardiography machine that's actually implemented one of the recommended techniques to minimize cross-contamination, such as the use of disposable plastic covers and shields on our echo machines and probes, which can be exchanged between studies. And so these types of creative infection control strategies can be utilized to help minimize risk of infection. Additionally, appropriate solutions should be utilized to sterilize our machines as much as possible between patient usage to also minimize cross-contamination. between our patients. There are also alternative echocardiography machines that may be considered, including the smaller portable laptop-sized machines, which are typically easier to transport and can be used at the bedside, and are also easier to clean as well. And again, we should also be very cognizant about the risk of exposure to our staff and to our trainees, and so allowing them to utilize some of these modified protocols as well as alternate equipment can also minimize the risk of transmission to our staff. So what are the types of PPE that are recommended when performing various studies? So their standard PPE that we recommend is using gloves, potentially double gloves if necessary, and a surgical mask, as well as upon glove removal, hand washing. So that's what we recommend for standard procedures for individuals that are either confirmed as not having COVID-19 infection or individuals that are low risk. However, individuals that are deemed to be higher risk or who've been confirmed as having COVID-19, when performing a transthoracic echo, we may opt for specialized droplet precautions. And so that includes hand washing, the use of gloves between patients that should be exchanged, use of an isolation gown. We should also be covering our hair with surgical caps and our shoes. Now, in terms of what level of mask usage should be utilized, for individuals that have stable clinical status, either on invasive ventilators or they have no active respiratory complaints, we may opt for a surgical mask. However, individuals that appear to have an unstable respiratory status where there's a higher risk of transmission of droplets within confined space or potential for aerosolization with active coughing, we may opt for more secure PPEs such as an N95 or an N99 mask. However, we should keep in mind that these masks have to be fitted for the individual, and so if an individual is unable to be either fit tested and deemed to be appropriate for available mask size, or if they've been deemed to not fit one of the masks that are readily available at your institution, then a PAPR system should be utilized. Finally, for studies that are higher risk for aerosolization, airborne precautions should be utilized. And the difference here is that it's recommended that N95 or N99 masks should be used, or a PAPR system if an individual does not fit any of the available masks. And surgical masks are not appropriate for this study. The American Society of Echocardiography released specific considerations for the protection of patients and echo service providers when performing perioperative or periprocedural TEs during the 2019 novel coronavirus outbreak. And in this supplement, they paid particular attention to the fact that TEs carry an increased risk of transmission of infection, as this is potentially aerosol generating procedure, and particular attention should be paid to when we are inserting our probe as well as removing our probe in non-intubated patients, as there may be transmission of droplets as well as aerosol due to coughing during these periods. Additionally, there may also be direct contact and transmission, as patients often have significant secretions. We may interact with these secretions as we're inserting our probe or removing them, and we may even contaminate our clinical space as well as our echo machines. And so we should be very selective when determining whether or not to perform these procedures and use the highest level of precaution when performing TEs. And airborne precautions thus are warranted in patients that are COVID-19 positive or that are highly suspicious, regardless of their intubation status. And so again, we should risk stratify each TE that we're performing and determine whether or not the study is absolutely indicated and understand the clinical status of the patient as well. And so if a study is potentially able to be deferred, or if we can glean the same information from an alternate imaging modality, such as a transthoracic echo, that should be opted for first prior to proceeding with a TE. However, if a TE is absolutely necessary, then it should be performed very carefully and being cognizant of what level of PPE we're using. And so what are some of the TEs that are absolutely indicated and should be performed with these appropriate precautions? And so they're typically urgent or emergent cardiac surgeries, patients with significant cardiac comorbidities that are undergoing emergent non-cardiac surgery. They may still require a TE depending on their exact clinical scenario. And if there's concern for hemodynamic instability due to undifferentiated shock in the perioperative period and we're unable to determine the etiology from a transthoracic or there's insufficient imaging quality, then a TE may be indicated at this time as well. Other surgical procedures that may benefit from having a TE study performed include individuals with infective endocarditis with valvular or paravalvular involvement, individuals with a type A dissection may also require an urgent TE to be performed. Upon insertion of temporary or durable mechanical circulatory support, we may opt for TE as well. Individuals with a myocardial infarction with concerns for mechanical complications, and again, if we're unable to determine what the exact pathology is from a transthoracic echo, or during our surgical intervention, if we need image guidance, we will typically require a TE at that time. And finally, when assessing a prosthetic valve, typically a TE may be indicated to further elucidate if there's any pathology. And so, how should we proceed with our TE if we are performing it? So there are various phases to the study that we should be cognizant about, and if performed in a comprehensive and structured fashion, we can maintain our personal protection and also minimize transmission of infection between providers and from patient to patient. And so prior to initiation of our TE, we should don our PPE appropriately, keeping in mind that we'll be using airborne precautions. And double gloves may be utilized as well during this time. Consideration should be paid to try to cover our ultrasound system if possible with plastic barriers that are disposable. During our study, we may try to minimize direct contact with our patient to only the times that are absolutely necessary, or minimize contact with patient secretions if possible. And we should also use modified protocols if possible to limit the amount of time that's spent during the examination. Finally, we should remove our outer gloves and wipe our inner gloves with approved wipes and solutions whenever other patient activities are absolutely necessary. And special attention should be paid to avoid any unnecessary contamination of surfaces, if possible, outside of the spaces that were indicated to use to minimize cross-contamination. After our TE procedure is complete, that's really when we should maximize the decontamination methods that we're utilizing to try to minimize any potential transmission of infection between patients and providers. So our TE probes should be removed from the patient. We should disinfect our probe, and we should place it in a closed container or biohazard bag. We should pay special attention to wipe all of our outer surfaces with approved wipes and solutions, as well as our equipment comprehensively. After this is performed, we can remove our outer gloves. Finally, we should then make sure that we wipe all of our equipment again with our clean glove prior to doffing our PPE. Then we can transport all of our equipment out of our clinical space into a clean area. And so this is an algorithm that was suggested for how to perform a TE during this time, particularly in perioperative patients, as well as individuals who may have advanced or interventional needs or congenital abnormalities. And so again, the concept is the same, where we should determine whether or not this is a study that could be performed at a later date and rescheduled, or if this is something that absolutely needs to happen. And if we've determined that this is a procedure that needs to happen, we should then proceed to determine whether or not we can determine the clinical status of our patient as well as their COVID-19 status. And when performing our study, we should try to minimize the amount of time that we spend while we're performing it, minimize our direct contact with secretions from patients, as well as minimize the amount of time that's spent in manipulating the probe for insertion and probe removal, as those are oftentimes the highest risk periods of time for aerosol generation. We can also collaborate with a number of our colleagues, especially for intubated patients, such as our anesthesia colleagues, who may assist us in intubation, as they're able to simultaneously perform intubation for patients to secure them onto the ventilator and then subsequently place a TE probe either through direct visualization, or they can place them in sequence to minimize the amount of time that the patient may potentially generate aerosolization or the amount of secretions that might be dispersed into the space. And so in summary, when thinking about best practices for our echo lab during this trying time, we should be thinking about whether or not we need to perform all of the studies that we're requested to do. And if necessary, then we should attempt to risk stratify our patients to determine whether or not they're clinically stable, and as we should also try to determine what their COVID-19 status is. And once we've determined their status, we can, for transthoracic echoes, use certain PP, and for transesophageal echoes, as well as for stress echoes, we should use some of our higher level PPs to minimize our, sorry, I'm gonna re-record this one. So in summary, when implementing best practices for the echo lab, patients should be risk stratified to determine the need for echocardiography testing. And if possible, elective procedures should be deferred, particularly in patients with suspected or confirmed COVID-19. Finally, additionally, COVID-19 status should be taken into consideration when we're determining best practices for PPE usage during our echo studies, as well as during our stress testing. And particular attention should be given to minimizing cross-contamination through echocardiography equipment, as well by using appropriate disinfection methods. And here are a number of resources that you can refer to understand best practices for performing echoes during the era of COVID-19. If you have any questions for me, please email CVI's Executive Director and questions will be sent to me. Feel free to share this link with anyone who might be interested in the information, and please let us know if there are any other topics of interest to you. Thank you for watching this CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org. Follow us on Twitter at #CVI Heartbites. Thank you very much.